I'm going to get things started here while we wait for everyone to join in. So welcome to the summer series of Grand Rounds. And I'm very excited that we have Bob McNamara here to lead off what we're calling here Faculty Spotlight Series. So Bob, thank you very much for joining us for this. So I will not do you justice in this intro, but I will do my absolute best. So we all know and, and respect Bob McNamara very much. Just by way of background, in case you didn't know all these, details about him, but Bob did his undergrad at the University of Notre Dame. I was pleasantly surprised to see that you're an electrical engineer as an undergrad, same as me, a medical degree from Washington University, and trained in internal medicine and cardiology from the Hospital of the University of Pennsylvania. He did his fellowship in ECHO at Hopkins and at ITEACH at the Hopkins School of Hygiene and Public Health. After a few years on faculty at Hopkins, Bob actually spent several years at the Chinle Healthcare Facility in the Navajo Nation before coming to Yale. Bob's been here at Yale for quite a number of years and has held several positions in leadership as the director of ECHO, program director for the Cardiovascular Fellowship, and currently the medical director of the Yale New Haven Ultrasound School. Bob's very well accomplished. He's a fellow of the AHA, the ACC, and the ASC. He's worked on numerous national guidelines and has also worked with CORE, the Center for Outcomes and Research Evaluation. Another key aspect of Bob's work, and this is an area in which he and I have interfaced quite a bit, is his focus in international work in medical education and clinical research. He has worked with the Yale Institute of Global Health and has collaborated in a number of countries, Colombia, Uganda, Dominican Republic, Rwanda, amongst many others. Bob is currently the president of ITEACH, which is a nonprofit dedicated to supporting education and exchanges in cardiovascular health worldwide. So Bob, it's an absolute pleasure and honor to have you here today talking to us. And I love the topic of your talk, by the way, on the focus and PoCUS. Thank you very much, Bob.
Thank you, Ire. I appreciate that, and thank you all for coming out on this summer morning to listen here, and hopefully I can make it worth it for you. Okay. First session, there you go. So, but before I go talk about cardiac ultrasound, I wanted to start by talking about the new technology in stethoscope that has just recently come out, of which you have far superior acoustic abilities to hear both cardiac and lung sounds, such that it really makes, in some senses, the old technology obsolete. Some people are concerned about the cost of it, but for the individual, you don't really need to worry about it because actually the hospital is going to buy these stethoscopes. As you can imagine, I'm not really talking about a stethoscope, but this is becoming more and more a consensus of what at least one way that people are looking at point of care ultrasound. So here are my disclosures. So hopefully over the next 45 minutes, as I go through 3 examples of how I've stepped out of my comfort zone it's related to pulmonary or from PoCUS, hopefully you can learn some other or gain some insights into some appreciation of some areas within PoCUS. So this is what cardiac ultrasound or any ultrasound, medical ultrasound, looked like in 1946. And this is what it looks like today, or at least that's what it looks like in the echo lab, but also in the emergency department and in the different ICUs. It looks like the cart-based. You can also have it as a laptop-based, whether it's freestanding or on a cart. And then there was the technology of the the handheld. And here was a GE handheld, which actually has the probe and the interface together. And then here's the Philips that has all the technology within the probe and can connects right into a standard Samsung tablet or other Android phones. And as many of you have probably heard about, Butterfly is one of the more recent ones and has developed a whole different technology rather than the usual piezoelectric mechanisms for creating ultrasound. They use a silicon chip, which is very standard in regular computers and makes it much less expensive. And although the images might not be quite what you're used to for the piezoelectric, it does a very good job. So the first comfort zone that I want to talk about for me regards echocardiography. Whether it's in the echo lab or at the bedside, I've been around long enough that I'm pretty comfortable diagnosing most of the, at least the standard cardiovascular complications, such like acute MI or the PE, and certainly the pericardial fusion. These are things we use, we see every day in the echo lab, but you can also see on the cardiology floors. However, on a day-to-day basis, mostly within cardiology, patients have already had their studies. So some of the major cardiovascular problems have already been diagnosed, and you don't need to follow them a day-to-day way. As opposed to, except with the exception of the pericardial fusion patients, whether they're before or after pericardiocentesis, most of the time that I've found the use for ultrasound on the floors has to do with fluid management. And within cardiac ultrasound, typical way to look for fluid, to see whether a patient was volume overload or not on ultrasound, was to look at their inferior vena cava, their IVC. If it was bigger than 2.1 centimeters and didn't collapse, that was more associated with volume overload. But how does it work? Maria Camila Trejo was a postgrad who worked with me and looked at this within the literature. And without getting into all the details, there was many articles that were looking at for patients with acute heart failure or chronic heart failure, typically as outpatient, how often did it predict readmissions or admissions or mortality. And as you can see here, it's relatively consistent. The studies were too heterogeneous to have a quantitative meta-analysis. But as you can see, most of them were positive, and overall there was some correlation. But as you can see, most of the odds ratios or hazards ratios, relative risks are between 1 and 2, which means that the effect is relatively modest. So how do we tell, how do we better use ultrasound to tell whether a patient's volume overloaded or not? And the key here is that it involves both water and air. When you're within cardiology ultrasound, usually the lungs are considered the obstacle. Patients with COPD have very difficult imaging. Ultrasound doesn't travel through air as well as it travels through liquid. That's why the police need to be essentially within a few hundred yards of a car to tell how fast it's going, but yet we can identify shipwrecks miles below the surface within the ocean. So somebody goes smart enough to see, well, what can we learn about these artifacts that can tell us that these artifacts between the air and the water. So I'm not qualified, nor do I have the time to give a full course on lung ultrasonography at this point, but can kind of give a few different points here. When you talk about the different ultrasound and different body parts, they're going to bring up many different of the radiologists and other groups bring up different transducers. Fortunately for lung ultrasound, the transducer that we use for the heart, the phased array, is perfectly fine for the heart. In addition to how do you do, how are we looking at the lungs? What kind of exam do we do? And if you see here on the right side, many of the literature out there was looking at a 28-zone method, which was pretty comprehensive. But many of the studies now and the clinical use has gone down to an 8-zone method. So without getting into too much of the details, some of the things you'll see on echo, on lung ultrasound that you can see here is called the bat sign. Often you're looking for that in a normal lung where the ribs are showing these two areas and the lung will be in the middle. You have here what's called the sliding ants. This is a normal finding to look at the ants marching, sorry, for lung sliding to show that there is a lung interface there, and not to get too concerned, but that's the way that people would diagnose pneumothorax is if you didn't have this. And there's plenty of other uses. We're comfortable with seeing pleural effusions, and also there's lung consolidation. But I'm not here to give a full review of all the lung ultrasound findings. But one artifact that you'll hear about is A lines, and these are the normal findings, or horizontal lines that are seen in normal lungs. And what we're talking about and that we concentrate on within cardiology is the B lines. And this is where that air liquid interface causes an artifact, which is a comet tail artifact that typically begins right near the ultrasound probe and goes through the entire field and straight for there. And that was what would indicate that a patient is volume overload. You wouldn't see it in patients with normal lungs. We can see up with patients with volume overload or pulmonary edema, and the degree of artifact seems to correlate well with how much fluid overload there is. Typically, 3 lines are considered positive on any field. But as you can imagine, that more would be more concerning, or more would be more pulmonary edema. So there's a whole lot of data out there regarding B lines. Most of it is in the emergency room or in critical care, where they're trying to differentiate shortness of breath or hypoxia of whether it's from a cardiac origin or whether it's from a non-cardiac origin. So many of the studies look at this. Here's just a meta-analysis with over 1,800 patients, and essentially came down with a sensitivity and specificity in the 80s. Pretty good. You can use that to differentiate whether somebody's shortness of breath is from a cardiac or non-cardiac reason. But how do we use that? There's also studies looking at it in terms of how we use it in clinical practice. So initially, there's a clinical workup, and you can determine how well you can tell without any labs or radiology imaging. And in this one study, in Italian EDs, they had a sensitivity and specificity before getting any lab work or imaging of 85% and 90%. The Italians were very good at this. But using lung ultrasound, they were able to get that up into being able to differentiate cardiac from non-cardiac causes of the dyspnea to 97% for both sensitivity and specificity, with a net reclassification of 19 patients. So essentially 1 in 5 patients were changed based upon the lung ultrasound. And this also looked at chest x-rays, just regular chest x-ray, and BNP. And the lung ultrasound outperformed both of them, or each of them. And actually, there was a clinical trial that looked at clinical assessment with lung ultrasound versus clinical assessment with chest x-ray and BNP, and the lung ultrasound outperformed the chest x-ray and BNP model. So as far as trying to differentiate whether somebody's cardiac or non-cardiac shortness of breath, it does pretty good. Within cardiology, though, we usually already know that it's due to a cardiac cause. And can we use it to help our patients that are already in heart failure? Well, there's less evidence regarding this, but there's still relatively a reasonable amount. Here you can see whether it's for acute heart failure on the top or chronic heart failure on the bottom, the hazard ratio is about 3 to 5 as far as whether you can predict readmission or admission. And these were for the acute heart failure, these were on discharge, whether the patients had B-lines at discharge and whether that was able to predict readmission, or in the clinics of whether patients had B-lines and whether it was going to predict admission. So there is some evidence for this. However, is it going to be used? I mean, it's something you can tell people all you want about how good it is, but it is something extra to do. And here's a quote: that it will ever come into general use, notwithstanding its value, is extremely doubtful, because its beneficial application requires much time and gives a good bit of trouble both to the patient and the practitioner. As many of you may have seen other talks I've given or guessed it, this was a quote about the stethoscope. John Forbes gave it back in the 19th century, and I think the stethoscope has stood the test of time to something that helps us clinically. But even that, how do we make it even easier? So it went from the 28 zones to 8 zones, and how about if you just looked at 2 zones? Well, I've had the opportunity to work with some colleagues in the emergency department. Christiana Balascu was a ultrasound fellow at the time when performing this, and now she's faculty. And Chris Moore is is the ultrasound director for the emergency medicine, and essentially was able to show that the just 2 zones performs similarly to 8 zones. Not quite as good, but there was no significant difference between the 2. So really, from the emergency department, many times clinically, they're just putting it on each side of the chest to determine, and it operates reasonably well. However, as you can see here, on some of these examples of B-lines, it can be very difficult. It moves around quite a bit, and trying to determine whether there's 3 lines in any given frame is up to some degree of interpretation. They are artifacts, and so many times you'd actually have more artifact, and 2 or 3 lines would merge into one, and how do you count that? So there is some concern that the variability among readers is generally high, and how do we make that better? So a second study that I was able to work with the colleagues in the emergency department, as well as engineers and computer scientists from Philips, was on an artificial intelligence in lung ultrasound. And this was looking at whether they could predict through deep learning what the experts would say. Or at least 2 experts would be able to do it. And you can see here on the one on the left, on the binary rating of whether there were B-lines or not, it discriminated very well. But over on the right, in the B with severity rating, anytime you have more categories that you can look at, the performance will decrease. But overall, it still operated pretty well. So, just as taking on a personal side, from here, I'm proud of many of the papers that I've written, but none more than I'm proud of for this one, because I got to collaborate with my daughter, and that was certainly a special experience. So I know that was a very brief overview of lung ultrasound, and certainly don't expect anyone to gain much value in being able to perform it, but hopefully it piqued some interest in maybe getting some people out of their comfort zone to be able to think about learning how to do lung ultrasound. Maybe if I can take a step back in some people's comfort zone, a little closer to some people's comfort zone, and just give one quick proposal on the post-pericardiocentesis issue. Usually within the ICU. So a patient after they've had pericardiocentesis, typically we found through the Yale data that they have 4.5 echoes before they leave the hospital. And all formal echoes, and whether this is truly necessary and whether this is helpful to have so many formal echoes is questionable. Because the typical process is the team sees the patients in the morning, they order an echo, a sonographer brings a big machine up at some point, does the echo, the images are read by us down in the echo lab, a report is given, and the information is given to the fellow and to get to the attending, and a decision is made. And this process can take hours, and often, I would say, probably contributes to some delay. However, I propose that if we can get facile in the point of care ultrasound, all of this can be done right away. And there is an order set already set up from the machine in the CCU, the Spark machine, that can be ordered. The fellow can be, or the attending can be obtaining the information, and everyone can be there at that time. The images can be sent down to the echo lab if there's any consultation needed, and the images are saved. However, no formal report is made unless one would need one, and then we could perform a full echo. But this way, decisions could be made right away at the bedside. That's just a little proposal I wanted to throw in there. So that was my, going back, that was my first foray outside my comfort zone. The second comfort zone I'd like to talk about regards echo education and training. My comfort zone is the echo lab. I've been there quite a while. I've seen many fellows come through the lab, and they're pretty comfortable that we do a good job. The sonographers are excellent in training the fellows how to perform the echoes, and then at various times they end up coming into the reading room, and I'm pretty confident by the time they're finished their fellowships, they understand what they need to know, depending on where they're going in their careers. Also, we often have visitors into the echo lab. We've had CT anesthesia fellows for years. And more recently, or in the last few years, we have SICU fellows, pulmonary attendings, pulmonary fellows come in. But it's still within my comfort zone. It's still coming down to the lab. However, more and more, the idea has been that we need to bring ultrasound out to the other people in the hospital. We don't have the capacity within the echo lab to train everybody that needs to be trained. I've just started sometimes going up to the CCU and working with some of the internal medicine house staff that are there, as well as the advanced practitioners, to see how well, to see if that can be something that can build on. We've done lectures within internal medicine, and we're trying to build a more formal curriculum. More recently, the hospitalists are interested. It's becoming a key core skill set for many hospitals to be able to do, particularly on the RRTs, the emergency teams, to be able to do point of care ultrasound. Now, obviously, when you start getting into this number of people, we need to have some other more formal way of training across the hospital, just for capacity reasons and resources. One of the interesting things, to take a step back, is that about 15 years ago, when I started getting more involved in point of care ultrasound, the reception within the echo community was chilly at best. But I think over the years, it certainly increased, such to the point that just over the last few months ago, there was actually a recommendation from the American Society of Echo looking at how to do point-of-care ultrasound training. I'd encourage everyone to look at this document that is interested, but just a few key parts of it is that they do try to categorize different echoes. One is just an ultrasound-assisted physical exam all the way on the left, and there's cardiac PoCUS, there's critical care echo, and then there's the two echoes that we're more used to that we perform through the echo lab, the limited echo and the comprehensive. So there's certainly overlap among these groups, but at least there's some ability to try to categorize how echoes should be used. And there's a whole lot in this document about training, about how you should go about training, where people should get it, how much they should do, and what are the resources that you need. And this is just to show that there's just become an increasing formality to trying to incorporate point-of-care ultrasound in training in various areas. And one proposal I particularly like is by an Australian group that they just divided into the 5 pillars of PoCUS, that you want to develop some governance, infrastructure, administration, education, and quality across the health system. Well, fortunately, we've been thinking about this a while, particularly Chris Moore in the emergency department, or the emergency medicine, has tried to, or has developed this committee, and we've been meeting over the last few years. It's multidisciplinary that includes as many people that have an interest in point-of-care ultrasound as possible, and it's certainly not exclusive. Anyone can join it. And to look to see if we can standardize various procedures across the hospital. All these, the training to make sure that there's quality, there's credentialing, which as you can imagine is always a sticky situation, but to standardize equipment, the data, particularly the safety of the data, as well as hopefully there'll be some research collaboration. So there's a lot to this, and it goes, it seems to always take a couple steps forward and a couple steps back. But hopefully we're moving all in the right direction at some point. What I'd like to talk about a little bit is the training part of it. One of the ways that I think we can increase training is with some of the technology that a software company called Caption Health is developing, and point of disclosure that I'm working with them to try to evaluate how well this is used. So they've loaned us this machine that is on a Terasan background, and the machine is Terasan, but the Caption Health is the software, and they're an artificial intelligence company. I can just walk you through this slide a little bit. Essentially, if you go to the top right here, whoops, yeah. In the top right, you can see that it tells you which view that it's trying to look at. Just below that is what in general it should look like. Below that is a figure saying where the probe should be put on and which direction the indicator should be pointing. And then all the way in the middle, I don't know if actually you can see my pointer. On the middle, there's a verbal direction, and that can either be slide in different directions, rotate the probe, rock the probe, tilt it up and down to get your better images, as well as there's some ability to have an image that's telling you what to do. And then finally, over on the left, there's a barometer that is telling you how close you are to the image. This is deep learning, so instead of, it's basically comparing the image that you're obtained to thousands of other images that have been obtained on other patients. It can tell you how close you are to what has been rated as ideal. Show you a little clip. Here, sonographer is just showing a subcostal view of how it's telling the sonographer to rock away from the indicator slowly, and then able to get the image. As you can see on the left-hand side, if you were watching, that bar went up, and eventually when went past an arbitrary line that said it was enough, that it was good enough, the clip is caught, is captured. So this actually, if you have a protocol like the one on the right, you can set up, either use the one that's from the company or set up your own, that you can then go through an exam pretty quickly. So that's very important about acquiring, and that goes into training to do the acquiring, but also people want to be able to do interpretation. And so one of the first things that we look for is the left ventricular ejection fraction. That's obviously very important within cardiology and in PoCUS. And in the echo lab, we typically try to quantitate as much as possible, whether it's by the 2D Simpson's method or by the 3D. And those are really what we try to do as much as possible. But really, in PoCUS, we're almost always using the eyeball method. And as you can imagine, this has a much higher degree of variability than the other quantitative methods. And certainly when you have the imaging within, or you have images with people with various degrees of training, you're going to have an even wider variability of ejection fraction. So this is one that the Caption Health is looking at, as among other people looking at, to be able to automatically do EF. And there's generally two ways to look at EF, or to try to do the EF. One is by looking at whether the edge detection within the image and trying to determine volumes based on the actual image. The other is, which the deep learning, which Caption Health does, is by just comparing it to thousands upon thousands of other images to determine what it's closest to, and to come up with an ejection fraction. And as you can see, they also have a degree of certainty next to it that has to do with the image quality, and how close it is to some of the other images that they have. I'll show you this. Is a peristernal view, and as you can see, it's giving information, giving directions of how to do it, what to do to get the best image. And on the left-hand side, you see it gets above a pre-described area or its prescribed level and saves the clip. And then on the right-hand side, you see this popped up over here. It gives an ejection fraction with this degree of certainty or uncertainty, actually, and that is something that can be done in the peristernal view, the 4-chamber and the 2-chamber, as well as combining all of them together. So it's not perfect, but certainly it is a step forward. And this company it's the first one that's out there that is FDA approved, actually, for both of these indications. As far as the image acquisition assistance that I talked about, was approved earlier in the spring, and this EF was just approved within the last couple of weeks. So that was the second area where I was, to come out of the echo lab and help and look at how ultrasound can be used in different areas within the hospital. My third comfort zone is the academic medical center. That's where I went to medical school, that's where I trained, that's where I spent most of my life. But as most of you know, the views from the IV tower can be very different than is happening in real life. So one of the areas that I've always been interested for a long time is global health. And many times when you think of global health, particularly within cardiology, you think of the surgery teams. I had the opportunity to work with one of them when I spent some time in Rwanda. And this was a surgery team called Team Heart that had, I think, 5 surgeons come over, multiple anesthesiologists, multiple cardiologists, nurses, technologists, a whole big team that came over, screened 60-some patients to find 16 patients to operate on. It's very fulfilling. One of mine in particular was a 17-year-old girl who I was able to identify outside of their regular screening and was able to get to have a valve. Obviously very life-changing for her, and it can be very personally satisfying. But as most people that work in this, you do get a lot of individual satisfaction, but you also think, how do I help more people than that? So this has led us to a whole group of us here within the cardiology here at Yale, develop the ITEACH team, the International Team of Educators Advancing Cardiovascular Health. And this is a wide array of people within cardiology, the cardiologists, the emergency medicine doctors, Mike Dewar, the surgeon, as well as fellows and medical students. And of course, Pilar, who keeps us all together. So this is a shameless plug for our nonprofit, but I'm using this venue for this purpose. And really it is to provide educational opportunities to improve the quality of care throughout developing and developed countries. And it's really centered on clinical and research collaborations. This is really the key. And I can't emphasize the idea of partnership as much as possible. That this trying to, when you go into education, it's less about unidirectional and more about a bidirectional relationship. And that's where the key features of it comes into it. So I didn't have to show this to Mike Dewar. He, for 10 years, had gone to St. Petersburg, multiple missions, multiple operations. He's doing a great job on an individual level and was teaching many surgeons and anesthesiologists and cardiologists and was doing a great job. But he even also realized that wanted to do more. So he partnered up with Masha, who's in the bottom left, who's a cardiologist in St. Petersburg and in the tour de force, to develop this program that will train as many people as possible. So one of the key aspects of it was to negotiate with the Yale New Haven Hospital to allow these Russian trainees, young Russian doctors, to come for 1 to 2 months and be able to participate with malpractice coverage, as opposed to most of the time that international physicians or other healthcare providers come when they can only observe, they were actually able to participate in the care, which is obviously a much better training opportunity. And so over those 12 years, there's been 60 clinical fellows. I think that's the last count that have come for 1 or 2 months. And he's continued 18 clinical trips to St. Petersburg and other areas in Northwest Russia. And more recently, over the last couple of years, this has expanded beyond cardiology to include oncology. So this is a growing field and a growing collaboration. Now, I'm getting to the point of the talk where I apologize if it seems like I'm the neighbor who invites you over for a slideshow, but I did want to, of their summer vacation, I did want to just show you the different areas. I realize that it's giving a much more breadth of what we're doing than any kind of depth, and would be very happy to talk over anything in more detail. So one of those, of course, our collaboration in Colombia with the Hospital Fundación Santa Fe de Bogota, which trained the famous Bernardo Lombo, who we all know and love. And he and I went in July of 2015 down there for the first time. And at that point, we went to a underserved affiliate of the Fundación to provide cardiac consultation to low-income and underserved community, which also included ultrasound on the patients we identified may benefit. And as is always, we like to provide care, but more importantly, we want to provide education and training. And so cardiology fellows, Colombian cardiology fellows, came with us out to this trip, as well as giving educational workshops to the patients and families there. But this, as great as that trip was, this collaboration is much more. There is an official relationship with with Yale, with La Fundación. Alfonso Esquero is sitting down signing. He was one of the founders of La Fundación, and he had developed a radiology imaging website. He was a radiologist and has officially turned it over to Bernardo in Yale to administer. And Bernardo has used this model to develop a cardiac imaging website as well. So I welcome all of you to look at these websites for both radiology and cardiac imaging. And in addition, we have had symposia down in Bogota each of the last 2 years, where both presenters from Yale and presenters from La Fundación gave lectures to a conference. The next one, or another one I want to talk about, is our collaboration in the Dominican Republic with INTEC, that already has a relationship with Yale and with the international group here. And we and our fellow Yulanka Castro can be seen in there on the right image. Is where she went to medical school. And so we had a collaboration, or we had an idea to go down there and had suggested that we teach some cardiac ultrasound. Well, they said, okay, that's great, but really what we'd like is if you went out to the clinics and helped with blood pressure control, with hypertension. That's a much bigger issue for us. And so, of course, the whole idea of ITEACH is not to tell people what they need to know. It's more to teach them what they think they need to know, which they're going to know much more than we are. And we were not only able to go down there and provide some education, we were able to help with a study to look at how, what the clinical inertia is within the clinics of treating a blood pressure, in hopes that we can use that data to have quality improvement programs. But in addition to the hypertension, we did have point of care ultrasound for those who needed it. And we did a session for the medical students in INTEC in Santo Domingo. There was a collaboration in Indonesia. There was a trip to Indonesia that I unfortunately wasn't able to go on, but a whole group of those from Yale went there and had collaborations with physicians that had spent time with us in the echo lab, some cardiologists that, and the trip went there and did a rheumatic heart screening in schools and was able to clinically help as well as to gain data and teach cardiac ultrasound, even to the point where a ultrasound machine was donated to them, at least as a loaner, to be left there so that they could continue to develop skills. Last year we had a collaboration in Argentina with one of the former fellows that had been here, was Marcos, I might get his name wrong, Chastagüe, and his brother Tomas, who's there in the picture on the far right center. And they were part of this group. There's a group down there that has developed a new PCR technique for determining prevalence of Chagas, and they were going to do a study out near their hospital, even out further from Cordoba, in one of the areas that is endemic with Chagas. And we went down there to provide some ultrasound support to find if there were underlying cardiac problems there. But again, it was going to a place where they had a need and they had already something developed that we could add some expertise onto. And we went there, just started a collaboration in San Pedro Sula in Honduras. As you can see, our very own Ceci Gallegos, who was a fellow at the time, is junior faculty, to go down there and provide some education. And even in the far right, there is the real Dr. McNamara. So I know this has just been kind of an overview of some of the things that we've done, but hopefully 10 years from now, that we will have moved from this bidirectional relationships and to be able to have some more, develop a true network. And just as an example here, some of the places we're going, but it doesn't have to be all centered here in New Haven, that hopefully there'll be some interactions among the different groups. And of course, would be more than happy to add groups as well. So within ITEACH, this is our mission. This is our saying is that the science of medicine is global, that we want to teach evidence-based medicine. We want to be able to do as much as possible. That applies across the globe, but the art of medicine is local, that each place is going to have different ways that they are going to be able to apply the science, and that's where the collaboration becomes so important. So hopefully I was able to show in this time some areas that I've gone out of my comfort zone that will provide some insight in where point of care echo or point of care ultrasound can be used in different areas, both here and across the world. And I want to thank everybody very much. There's way too many people to thank to put on a slide, but I want to thank the people in my comfort zone from the Echo Lab and in cardiology. They've always provided the base, but also to go out within the YPUC community, all the other people at Yale to teach lung ultrasound and to find out what different ways that the ultrasound can be used. And of course, my ITEACH colleagues of where we're going to work across the world, and all the international colleagues that we work with. Special thanks to them. And in particularly, this being the first grand rounds that we're streaming out to various places. To these colleagues that I've talked about in Colombia and Argentina and Dominican Republic and Indonesia and Russia, that will be able to provide that collaboration, that hopefully that they can benefit from some of our teaching here, as well as they hopefully at some point can contribute and we can learn from them. Thank you very much. I'd be more than happy to answer any questions now, as well as anytime that you see me or email to get anything more in depth of anything I've talked about. Thank you.
Bob, thank you so very much. That was excellent overview of ultrasound, and also an excellent overview of the amazing work you've been doing with ITEACH. I did want to jump in as well, just to, extend my welcome to our colleagues who are joining Cardiac Grand Rounds, as you mentioned, for the first time, from Colombia, the Dominican Republic, from Russia, from Indonesia, and Argentina. We are so incredibly glad to have you here in this forum. Thank you very much, and we look forward to having you in future Grand Rounds. I'll now be happy to take any questions for Bob. You can feel free to ask questions in the chat. And Bob, we have a few questions already that came in, and if there are any new ones, I will certainly sort of pass that along. I have Ramon Peralta asking about how important should an ultrasound be in the assessment of chest pain?
Well, I think it can be very valuable. As in any tool, it shouldn't be the primary thing that should be thought about. But certainly when you have a differential and when you're concerned, if you think this is ischemia of how how much it's affecting the heart, you can get imaging. Certainly we use it in patients with known pulmonary embolism that come in with chest pain. Usually that's something that's already done after the diagnosis of pulmonary embolism. So I think that it can be used, but certainly it should not be a frontline item.
Thanks, Bob. I guess, one question from my perspective is, sort of this tension that you've mentioned, especially within cardiology between sort of, the echo and, either a comprehensive echoes or limited echoes and the use of, point of care ultrasound, which seems, and I think it's fair to say that does not have as much, uptake or use, for cardiologists. So how do we sort of, reconcile this? Is this something that, on the floors in the wards, we should be training on and using, more comprehensively than we are now? Of course, knowing that it doesn't supersede the work that we do with, our histories or physical exams, but how do we reconcile that tension?
Yeah, no, that's an excellent question. It gets difficult. I mean, for a while, the machine, the equipment was the big difficulty that radiology or cardiology had all the access to the equipment. So really, unless you were going to be an expert in it, you would need, you wouldn't be able to use it. But now that the technology has become much more widespread, the prices are down, that these machines are in various places across the hospital, and it really comes down to training. And I think that's the big issue, that I think once people get comfortable with it and get training, they'll use it much more. I mean, when I'm in the CCU or I'm in the cardiology floors, just carrying the point of care ultrasound around, it really helps. And as I mentioned before, for the most part, 90% of the time, I'm using it to determine B lines for lung ultrasound. Most of the patients within cardiology already have echoes, and most cardiology findings don't necessarily change on a day-to-day basis. Now, that being said, as far as training outside of cardiology within internal medicine and the hospitals and like that, they need a broader, capability, because patients, sometimes the heart part isn't, the cardiac part is not known. But to address your problem, yes, I think that we as cardiologists need to understand lung ultrasound, particularly B lines, and that it will be something, I don't know if it's 5 years from now or 10 years from now, where so many people will be using it that the cardiologists that don't use it will feel at a disadvantage.
Thanks, Bob. I think as a follow-up to that, Marian Sadeghi is asking, your thoughts on the potential gaps in cardiovascular medicine that PoCUS can address, maybe, beyond maybe doing the same thing in an easier way. So are there new frontiers, new things that we're not doing at the moment that we could, potentially be addressing with PoCUS?
Well, right. I think that PoCUS, as far as ultrasound goes, is mainly the application of what we already know. I mean, most of the PoCUS things, other than some of these ejection fraction AI, will use the technology that we have on bigger screen and bigger machines, and where we can apply it. So the idea is where to use it. So the idea of that you can have these relatively inexpensive machines and put them out into the field is key. Whether it's here in the United States, whether I was here or when I was in Rwanda, there is just a large amount of normal or near normal echocardiograms. Sometimes it's very difficult to say when a patient has shortness of breath, when they have certain problems of what it is. If a practitioner could screen them for the major problems, I think many of the times people would feel comfortable that they didn't need a full echocardiogram. So I think it's just the application of it. Certainly, even within our clinics, but even more than that, out in the area, in rural areas in particular, where if you want to get a formal echocardiogram, people may have to travel hours to get it. If you can screen them, at least for the major problems, then that would be helpful. And that can, certainly be outside the realm of cardiology, and you won't be able to just have cardiologists doing this. It will need to be other practitioners, physicians and non-physicians alike. So I don't know how much that addressed the question, but I think that's it's more of an application issue than developing new technology based on ultrasound. But certainly using a lot of the new AI technology to improve diagnosis, to improve ability to get the images that you weren't able to get before, is going to be the game changer.
Thanks, Bob. Other comments? Dr. Velasquez, I thank you.
Yeah, so Bob, great work, and we've talked a fair bit about this and the challenges, particularly in expanding PoCUS into regions of the world where there's less capacity as well as less skill in delivering echo. So I guess the question I have for you is, can you speak about what I would call hybrid imaging, where we are starting to kind of integrate machine intelligence to not only guide the placement of probes to get the best images, but also to kind of spell check function the interpretation. I mean, do you envision this being a strategy to expand PoCUS, particularly among non-healthcare workers or non-traditional healthcare workers in the developing world?
Yes, if I understand your question, I mean, I think that's exactly how much of this can be used. That the idea that the machine, ultrasound technology and the big machines is very expensive, requires a lot of expertise, really limits the capacity. I mean, we have ultrasound machines, plenty of them here, and we generally can accept the demand for it. But in many places, that's not the case. And to be able to have this technology out in the, out in more rural areas is going to be very key. And now we can do the machines because they're not as expensive. But as you mentioned, it's really the expertise and how to coordinate that expertise so that you have enough training for them to begin with, but enough assistance, whether it's through AI or through some sort of telemedicine, to be able to have expertise. That's another area we're working on. I didn't talk about it here today, but where the images can be sent in real time while someone's obtaining the images to help. So I think that's where this technology can help and can really change how the practice of medicine is in various areas. As you mentioned, particularly in the developed world or developing world, but I think it's also going to infiltrate in many different areas, even here in the developed world.
And one maybe a follow-up question, Bob. What I think traditional kind of gold standard RCTs are going to be probably unlikely to be the best strategy methodologically to understand the efficacy of those approaches when they're tested, and I think we do need evidence to guide funders to invest in these activities. So I guess I'd just be very curious, in your experience, what would be methodological strategies that you would apply to kind of get us over the hump with regards to the evidence to kind of pull funders off their seats?
Yeah. Well, as you know, yes, and as you mentioned there, in these practice application studies are areas it's very difficult to do randomized clinical trials, particularly in diagnostic imaging. In therapeutics, you're much closer to the endpoints of the diagnostic. Your endpoints are often not quite as hard as you'd like them to be. But that doesn't mean that we shouldn't be trying to get various evidence. So, I think you need the wide array that's out there. There's different people are trying different things, and you can just initially start with some, the cohort studies to determine what's working, but you really need to evaluate the benefit. Any new technology, it's easy to say it helps, but to really show that it helps, is the key to doing it. So, a lot of different studies with some of the STEP trials where you can try the application and see how it changes in different areas. One of the things that, as you know, that the difficulty is that the ultrasound companies are the ones that are out there that, of course, want to project this technology out there. And so some of the more traditional funders, the government funders, don't view this as their job. But often these vendors don't have the money, or at least they don't have the money in their research to provide the trials, whether they're randomized trials or other clinical trials to do it. So there is a gap in the ability to get these to get the evidence that you would need of how best they can be. Sure, we could put these across the different world, but what's the best, where to put them, who to train, how's the best training mechanisms, how much you should have the initial training, how much you should have the continuous training, is a very difficult thing to establish, but definitely very important.
Bob, thank you again very much for an excellent talk, and it's very much appreciated. And also we appreciate our colleagues who've joined, specifically, joining first for this talk. So thank you everyone again, and we look forward to seeing you all again next week. Same place, same time. We'll have some wonderful debates from our fellows next week. Thank you.
All right. Thank you all.
Bye.